Welcome everyone. Today we're going to talk about complex distal radius fractures, which are actually better described as wrist injuries because they combine the bone component with different degrees of articular instability. We're going to go through the main components of complex distal radius fractures, the basics for initial evaluation, which lay the foundation of how these injuries should be approached. I will also show you some cases to illustrate treatment principles and strategies for surgical management that will hopefully become handy at some point. These injuries are the result of high-energy trauma, frequently on patients that practice high-risk activities that usually have higher expectations regarding function and returning to work and sports. Despite surgical treatment, there's a higher risk of loss of fixation and persistent instability. However, if these challenges are understood and well managed, we can meet good results. Recognizing energy of trauma is the first step in establishing a course of action. Even though we might get articular comminution after a low energy trauma in a patient with bone fragility, these injuries are not comparable and should not be addressed in the same way. The goals are the same as in other articular fracture, restoring the anatomy and properly stabilizing the fracture to ensure a prompt and secure mobilization to regain function. We face two main problems when we treat complex distal radius fractures. Number one, the fragment. Line fractures are usually at or beyond the watershed line, and we end up having multiple and small fragments with loss of metaphyseal support that make fixation a real challenge. Number two, instability. Ligament insertions remain attached to the fragments, and stability of radiocarpal and/or distal radioulnar joint gets compromised. Fracture lines follow paths in between ligament insertions, and although a high-energy distal radius fractures can result in an infinite combination of fracture fragments, there are some more or less predictable fracture patterns and 5 typical articular fragments that have the potential to be reduced and secured to a stable metadiaphyseal segment. These are the volar rim, the dorsal ulnar corner, intra-articular fragments, dorsal wall, and radial column. Axial load injuries tend to occur in 2 patterns of instability depending the direction of the translation of the carpus. In the dorsal pattern, the lunate impacts the intermediate column and it subluxates dorsally, and the volar ulnar corner or teardrop fragment rotates dorsally and extends. In the volar displacement pattern, the volar rim displaces volarly and proximally with the carpus, maintaining the angulation of the teardrop. In both cases, we find the other classic fracture fragments, of course. Avulsion is another instability pattern which is less common. It's more of a carpus dislocation with very small bony avulsions than a distal radius fracture. The intermediate column is the primary support of the load that goes through the wrist, especially the volar aspect, which is known as the critical corner. We can see how this area is thicker than the rest. And this is where we focus our attention when we want to evaluate the mechanical alignment of the joint and translational stability. So much that if the critical corner escapes the fixation, the whole carpus dislocates with it. Because it includes the sigmoid notch and lunate facet, it may cause radiocarpal and distal radioulnar joint instability. And restoring the length and the volar tilt of the intermediate column is a priority to correct the mechanical axis and stability of both joints, and also set the foundation for the reduction of the rest of the fragments. The radial column maintains the carpal height and it leads to a smooth distribution of load through the wrist. Inability to correct gaps between the intermediate and radial column stresses the scapholunate ligament, which in turn alters carpal kinematics. Moving on to treatment alternatives, I will go over 4 of them, which need to be tailored according to the personality of the fracture. Let's go over the first case. This is a 52-year-old woman who fell down the stairs several floors. This is a complex fracture with an axial dorsal instability pattern, but there's so much impaction you can't quite tell what's going on. Traction views are very helpful in this scenario. I believe now in these images we can understand better what we're going after in this case. CTs are not mandatory, but they also help us understand the fracture and measure the volar cortical distance. When we have an isolated volar ulnar corner fragment, this distance determines whether we can fit a volar locking plate or not. In this case, it was 12 millimeters. Also, the comminution is more metaphyseal than interarticular, and the radial styloid is big enough from ulnar to radial to put at least 2 screws. This is why I picked a VLP. However, I had to put it a little bit distal, and even though it hasn't caused any flexor tendinosynovitis yet, that is something to keep in mind during the post-op. Removal might be necessary in some cases. Also, during the procedure, we have to be certain that there are no interarticular screws, which is a complication of going over the watershed line with the plate. Whenever we have a volar cortex distance less than 15 millimeters, we have to start thinking on alternatives to volar locking plates. This leads us to our second alternative, fragment-specific fixation. It is really a philosophy of care more than a technique of the complex distal radius fractures. It allows us to restore anatomy and stability with tailored constructs according to what the patient and the fracture need. In some cases, we can start rehab really early, as we would do with a volar plate in a less complex case. This is a 48-year-old patient who fell from height during work, sustaining a fracture with the 5 classic fragments, very distal. We got a great result, but the only way to get result is following the principles. First step, identify the fragments. You have to make sure you get very comfortable at identifying them on the simple x-ray, because that's what you're going to have in surgery. Going back and forth between the x-ray and CT images is helpful, but I highly recommend reading this article if you want to become a master on distal x-rays. Next step, reduce and fix each fragment independently, starting with the volar ulnar corner. In this case, the fragment was so small, less than 5 millimeters, that I used a buttress pin plate. At this point, we look for correcting the teardrop angle, and we assess that in the 10-degree lateral view. I then went dorsal. First, fixed the dorsal ulnar corner, and then packed some corticocancellous bone graft to uplift the interarticular fragments before we close up the dorsal wall. I used 2 dorsal pin plates. This use pins for the fragments, and the plates provide further stability to the pin and add a buttress effect to those fragments. At this point, we evaluate the correction of the radiocarpal alignment. A tangential line drawn from the volar cortex should pass just anterior to the center of the lunate, and 2 concentric circles should form, prolonging the distal radius and proximal lunate articular surface. Having a stable intermediate column allows us to reduce the radial styloid onto it, building a load-sharing construct. These are semi-elastic plates that avoid drilling and using screws, which could fracture the fragment even more, and they are low profile, which allows for more distal placement. Again, aiming for a secure and functional recovery. This is another case. It's a fracture with a volar instability pattern. there's a double fracture on the volar cortex, so we end up with a very small volar ulnar corner fragment. But the CT shows a big dorsal fragment on the intermediate column, and the dorsal lip has an avulsion, but it doesn't compromise stability or articular congruity. In this case, I used a volar hook plate for the volar ulnar corner fragment, and you can put a screw through that plate that goes subchondral all the way to the dorsal ulnar corner, so we can skip the dorsal approach and dorsal fixation. Meanwhile, for the radial column, I needed 2 plates to counteract the volar and radial displacement. Different construct, same principles. In cases where the instability pattern is dorsal and the fragment of the dorsal wall and dorsal ulnar corner are small and unstable, it is necessary to fix the intermediate column both volarly and dorsally. We could not use the construct we used in the previous case. It's not unusual to have a coronal split to the radial styloid. In these scenarios, using a single radial plate may be insufficient. Using a 90-90 degree configuration, we can control both planes and displacement. You can see how the construct is tailored to the fracture and not the other way around in every case. Results are good to excellent in the literature, but you need to follow the principles. Moving on, external fixation achieves reduction through ligamentotaxis. It controls carpal translation and axial load. It's quick, it's minimally invasive. The bridge plate offers a similar effect as external fixator, but it is easier for the patient to manage in the post-op. And because it avoids contact with the extensor tendons, it's easier for the patient to move their fingers from the beginning. However, adequate reduction is obtained only in half of cases where ligamentotaxis is used, and loss of reduction is expected in the following weeks if used isolated for complex distal radius fractures. Results between them are similar. However, infection is not only a little bit higher for external fixation, but it also appears between the first 5 to 7 weeks. Sometimes the fracture hasn't healed yet, so even though it is a superficial infection most of the times, it demands removal of the external fixator before the fracture is stable enough. No matter what we choose to use, whether it is an external fixator or a bridge plate, we have to keep in mind that some fragments don't reduce under traction. That's the case of the volar ulnar corner, the critical corner we've talked so much about. It rotates dorsally under traction, leading the fracture to heal with articular incongruity. Having said that, these systems should be used only as supplemental fixation to internal fixation of critical fragments. This is a 35-year-old patient who was involved in a motorcycle accident presenting to the ER with this fracture. This case has more metaphyseal comminution, so there's a total loss of support for the articular fragments. This is a great case to supplement with a bridge plate or an external fixator. I start by placing a plate at the volar ulnar corner so I can move the fragment freely. Afterwards, I apply traction and the fracture improves substantially. Again, if we take a closer look, we can see that the teardrop angle is still closed. The dorsal wall is displaced dorsally, and we have a greater AP distance, so we can infer there's a coronal gap in the intermediate column. The carpus is shifted slightly dorsal because the bridge plate worsens the carpal subluxation when the dorsal wall is unstable. No need to say I have a 4-year-old and I know all the socks. Fixing the intermediate column corrects the corpus translation and articular congruity. And finally, the fracture successfully heals. I want to close this talk with some final thoughts. Complex distal radius fractures are more than that. We must think of them as wrist injuries and treat them likewise. Boulder locking plates are probably not the best option in most cases, but above all, the concept of one size fits all does not apply here. Ask about the energy of trauma, identify your fragments, how many, how small are they, and look for instability patterns. Thank you so much for your time and for the invitation to speak about a subject I'm very enthusiastic about. Until next time.